afternoon too. My name is Honorable Balabangbala, and it's my pleasure to welcome you all to today's Gynecological Cancer Awareness Seminar, organized by Eko Club Philadelphia. Our mission is to raise awareness and share vital information, especially with our mothers, sisters, and daughters. Share about gynecological cancer. Before we begin, I would like to acknowledge the president of Eko Club Philadelphia, Honorable Olabisi Dabri Okoya, for our dedication and leadership, as well as the executive team and all our esteemed members. Under the guidance, Eko Club Philadelphia has led impactful initiatives, including Ronald McDonald's House, Adopt a Highway, scholarships, back to school programs, Thanksgiving turkey giveaway, winter coat drive, and health seminars. Now, it is my great honor to introduce our distinguished guest speaker for today's seminar. I'm sorry. Dr. Mona Saleh is a fellowship trained gynecologic oncologist who grew up in Mercer County. She completed her fellowship in gynecology oncology at the Eastern School of Medicine at Mount Sinai in New York, New York. Following her residency in obstetrics and gynecology at New York University Grossman School of Medicine, where she serves as research and quality improvement chief resident and trained in robotic surgery. Dr. Saleh earned her medical degree from NYU Grossman School of Medicine and completed her undergraduate studies at Rugged University, New Brunswick, graduating summa cum laude. Her clinical expert focuses on cancer and precancers of gynecologic origin, with a special interest in minimal invasive surgery and enhancing access to cancer care for all communities. Dr. Saleh has also contributed to medical research, publishing in various medical journals and presenting at both regional and national conferences. Additionally, she is fluent in Spanish and Arabic. Please join me in giving a warm welcome to Dr. Mona Saleh. We look forward to your insight. The stage is yours. Thank you very much and welcome.
Thank you.
Thank you so much for that introduction.
You're welcome.
So let me share my screen. Okay, I'm sharing the screen now, so hopefully everybody sees it.
Yes.
Perfect. So, hi everybody. Good morning, or good afternoon, depending on where you are. My name is Mona Saleh. I'm a GYN oncologist. I'm here to talk to you all about cancers in women and how we can prevent and detect gynecologic cancers. I don't have any disclosures. So I have basically three objectives for this talk. At the end of the talk, I'd like everybody to be able to identify some symptoms of GYN cancers that should prompt you to see your doctor to be evaluated. I would like everyone to know modifiable risk factors for gynecologic cancers. And then I'd like everybody to learn some interventions that we can all do to reduce our risk of gynecologic cancers. So I just wanted to start with this very basic diagram. I know you all know this. but I use a lot of diagrams when I talk to my patients. So this is the female reproductive system. We have the vagina here and the cervix, the uterus. Within the uterus, we have this triangle-shaped space called the endometrium. This is also called the womb, where a baby would grow. We have two fallopian tubes and two ovaries. So I'm going to talk about endometrial cancer, and then ovarian cancer, and then cervical cancer. In the US, cancer is the second leading cause of death among women, just after heart disease. So cancer accounts for 21% of female deaths in the United States. So it's something significant. Uterine cancer is the first one that I'll discuss. So uterine cancer or endometrial cancer is the most common gynecologic cancer in the US. The risk of this cancer is about 2.8% lifetime risk. The average age of diagnosis is 62 years. I really want to focus on that because for this and most other cancers, honestly, the older that you get, the more at risk you are of developing cancer. I have many patients that will tell me, I stopped seeing my gynecologist after I finished having my babies. I didn't know that we needed to continue to see them. You need to see your gynecologist every year. And one of the things that your gynecologist is doing during your exams or when they talk to you is seeing if you have any signs or symptoms of various cancers, including uterine cancer. 75% of women with uterine cancer are diagnosed after menopause, which is typically around age 50 or 51, depending on the country. 25% of women are premenopausal, and then 5 to 10% of women are quite young for this, under 40 years old. There's various risk factors for uterine cancer. I want to draw attention here to a few big ones. Obesity is a big one. Obesity, especially being more than 50 pounds over the ideal body weight for you. Having diabetes, being on tamoxifen. If someone had breast cancer and then is in remission and taking tamoxifen, that does increase the risk of uterine cancer. And then a genetic syndrome called Lynch syndrome also increases the risk of uterine cancer. Protective factors against uterine cancer: pregnancy. So a woman who has been pregnant more times is going to have a lower risk of uterine cancer than a woman who has never been pregnant. Having a late onset of first period with over 15. This is quite late, so this is uncommon. This is more common in an Asian population, but in women who are, not Asian or not white, very uncommon to get your period this late, and actually more common to get your period earlier. Another protective factor is you using birth control pills or having used birth control pills in your life. This is the most important slide in this presentation. So this is what I want everybody here to take away, is that the most common sign and symptom of endometrial cancer is bleeding after menopause. What does that mean? Bleeding is red blood. It can be pink blood. It can be brown blood. It can be one spot after you wipe, after using the restroom. It can be heavy like a period. Even if it happens one time and it never happens again, please see your gynecologist or your primary care physician to let them know this has happened. And I would request that every woman here today, please, after this presentation, tell one other woman that bleeding after menopause is never normal. It's never normal. Just tell one other woman, your sister, your mother, your girlfriends. Tell one other person, because this is something that time and again I have found people don't know. Sometimes there's doctors that work maybe in a different field and they don't know this either. So we really want to make sure everybody knows this. After You go through menopause, you should never bleed again. So that's the most common symptom of endometrial cancer. If someone is still having periods for a very long time, like if a patient is 60 and they're still having periods, it's a little unusual. They might actually be bleeding from a uterine cancer, so that should be worked up. For people who are still in the reproductive age, if they have a significant change in the pattern of their bleeding, let's say they have light periods typically, and then all of a sudden they have very heavy periods, that should be evaluated. If people have bleeding between periods or something, another way I've heard this said to me is a patient will say, I have 2 periods every month. That's not normal. That should be evaluated. Sometimes people have very severe pelvic or abdominal pain when they have this cancer, or they can have unusual vaginal discharge. All of these things should prompt you to see your doctor. And then what we would see on our exam in the later stages, if somebody has a pelvic mass on exam that's concerning, or if the endometrial lining, that space in the uterus that we looked at in the picture, that would appear thick on ultrasound. And in menopause, it's supposed to be very thin. So this is another important slide. So the reason that obesity causes an increase in the risk for endometrial cancer is because our fatty tissue converts cholesterol into estrogen. When you have more fatty tissue, you're going to have more estrogen. You're going to have a higher conversion to estrogen. This estrogen is going to stimulate the uterus, the endometrium, and it's going to cause those cells to respond as if you're having a menstrual cycle. And those cells will be stimulated and they will change and they will mutate. And if they mutate or change into a cancer cell, once a cell becomes a cancer cell, it can just take off and clone itself very quickly and indefinitely. So having that excess fatty tissue is one thing that will increase our likelihood to get endometrial cancer, but it's also something that we can control. When people lose weight, you decrease that risk of endometrial cancer proportionally. Obesity is definitely a big health concern, and it's multifactorial. There's a lot of factors that contribute to obesity. It's not just, people eating too much. Our genetics play a significant role. If people have other medical issues, it can affect them being obese. So we definitely recognize it's not easy to lose weight. And, I always offer my patients how to discuss how I can help them to lose weight. So another thing about endometrial cancer and obesity is really the mainstay treatment for endometrial cancer is surgery. When someone is obese, that makes surgery very risky for them. Sometimes patients can be so obese that they actually are not even a candidate for surgery. Surgery is just too unsafe for them. So there's, multiple reasons to do our best for all of us to be in a healthy weight. There's a genetic syndrome called Lynch syndrome that has increased risk of uterine cancer and colon cancer most commonly. It does put people at increased risk of these other cancers listed here, ovarian, pancreatic, etc. But really uterine and colon are the most common. How do patients know if they have Lynch syndrome? Well, they would need to get genetic testing. What I tell people is always know your family history. Do your best to learn your family history. Know who had cancer, what kind of cancer did they have, and how old were they when they were diagnosed. If I have a patient that gives me a whole list of family members that were diagnosed with various cancers at young ages, that makes me suspicious that there's some genetic component to it. And for those patients, I will send them for genetic testing, which is a blood test. I encourage everyone on this call to be open with their families about medical diagnoses that they have. I know this can be difficult, and I know that there is, cultural and generational component to this. I know some families don't talk about cancers in the family, but I really will tell you from a physician standpoint, an oncologist standpoint, um, family members will benefit. The reason is if someone knows they have a genetic syndrome that can cause cancer, and they know that before they themselves develop cancer, we can do things like increased screening or sometimes even preventative surgery so that they don't develop that cancer. So endometrial cancer prevention, you can maintain a healthy weight, exercise, walk. If you can't do anything else, walk. Um, know your family history, and then really talk to your doctor. Talk to your doctor, know about postmenopausal bleeding and know that's never normal. And be very quick to involve your physician, whether that's your gynecologist or your primary care physician. If you're feeling differently, you're feeling that something might be wrong, please see your doctor. Um, yes. So to summarize uterine cancer, like I said many times, postmenopausal bleeding always needs to be evaluated. In order to confirm the diagnosis of endometrial cancer, your doctor would do a biopsy. Most of these cancers are diagnosed at stage 1 because this postmenopausal bleeding symptom presents early. If, though, a patient has postmenopausal bleeding and they take a long time, like several months or sometimes even several years, to go to their doctor and be diagnosed, that cancer will spread during that time. There is no effective way to test for uterine cancer. So we really just need to keep a close eye on symptoms. And again, know your family history. The next cancers that we're going to talk about is ovarian cancer, and we group ovarian cancer and fallopian tube cancer and something called primary peritoneal cancer all together because we believe they come from the same cell line. And actually, we believe that even 75% of ovarian cancers actually start in the fallopian tube and travel their way down to the ovary. Ovarian cancer is considered a rare cancer, but this really can be a devastating cancer diagnosis to get most of the time. It's the 5th leading cause of cancer death in American women. Most women are diagnosed in what we call the advanced stage, stage 3 or 4. That's up to 80% of women. The cure rates for ovarian cancer are not good. They're really not good. It's very difficult to cure this in stage 3 and 4. And what I actually tell my patients at these stages is that we can treat it, but we're not going to reach cure. There is no effective screening test for ovarian cancer. What are the risk factors for ovarian cancer? If you have a BRCA1 or 2 genetic mutation, your risk of ovarian cancer is extremely high. These numbers mean you're at 14 times to 35 times more likely to get ovarian cancer in your lifetime. If you have a female relative with ovarian cancer, your risk goes up. That risk goes up when the relative is closer to you. So if it's your sister, that risk is higher than if it's your cousin that has it. Advancing age is a risk factor. If a woman had issues with infertility, or if she was never pregnant, that actually increases your risk of ovarian cancer. These green ones are protective factors. So if a woman has had a hysterectomy in the past, and she still has her ovaries, or she had her tubes tied, that decreases your risk of ovarian cancer. Taking birth control pills for 5 years of your life decreases your risk of ovarian cancer as well. This is usually a painless cancer without symptoms in the early stages. In the advanced stages, people will usually have a large ovarian mass, or they will have a lot of fluid in their abdomen. This cancer produces a lot of fluid, something called ascites. So the abdomen can appear swollen. So in advanced stages, when patients will present, they usually have pain, urinary changes, swollen abdomen, change in appetite. They're getting full faster when they eat. They can usually finish, a big piece of chicken, but now they can only eat a small piece of chicken. Or they usually drink this much water, but all of a sudden they're only able to drink half of that. That's a very common symptom. I would pay close attention to this one. And then changes in bowel habits, diarrhea, constipation, or nausea or vomiting. Um, when a patient has ovarian cancer, we always recommend they see a gynecologic oncologist rather than a regular OBGYN for their care. Some places, including in the US, depending on where you are, it is difficult to find a GYN oncologist specifically because it's a small group of physicians, but typically the outcomes are better when you see a specialist for this. So most ovarian cancers are not genetic, but about 5 to 10% of them are. Most of them are from this BRCA1 mutation or BRCA2 mutation. Um, BRCA1 and 2 mutations are also even actually more associated with breast cancer. So if in your family many women have breast cancer, that's another reason to see if you can talk about getting genetic testing to see if you are a carrier for these mutations. In BRCA mutations, patients have a higher risk of breast, ovarian, and pancreatic cancer, and men can have these mutations too. Um, Actually, men can get breast cancer as well. They're much higher risk of getting breast cancer when they have this mutation. They're also at risk of prostate and pancreatic cancer, among really a variety of other cancers. So if there's a family with a very high breast and ovarian cancer burden, many family members affected by those, really would recommend testing males and females for the BRCA mutation. So the summary of this is that the symptoms of ovarian cancer are very vague. There's no good way to screen, and it's typically diagnosed at an advanced age. So we have to pay very close attention to our symptoms and our bodies. Know your family history again, and if you're diagnosed with ovarian cancer, see if you can find a GYN oncologist to treat you. The next one I'm going to talk about is cervical cancer. This is a lot of American data, so it does not apply outside of the US, but what I do know is that cervical cancer is much more common outside of the US. Um, so this cancer affects women who are a bit younger. The average age is in the late 40s, early 50s. This cancer occurs more and has a higher death rate in women who are African American in the US. Really the only important risk factor for cervical cancer that's on this slide is HPV. HPV is a virus. It's called human papillomavirus. Let me see if I have slides on that later, but I will talk about it. HPV is human papillomavirus. This is a sexually transmitted virus. You do not need to have actual intercourse to get HPV. HPV lives on the outside of the genitals of both men and women. 80% of sexually active adults will have HPV in their lifetime. This is extremely common. This is a very common virus. So it's very important to try to protect ourselves against it. Even if you have sex using condoms, it's not going to protect you from HPV because HPV lives on the outside of the genitals, and intercourse, penetration is not required to transmit it between one partner to the other. So if a person is smoking, or if they have some history of immunosuppression, let's say they've had an organ transplant and they take anti-rejection medications, they're at much higher risk of having the HPV and the HPV staying. Most people will clear HPV spontaneously within 1 year. Their body will just get rid of it. But if you smoke, you're not healthy, you have other medical problems, you're not going to clear it at the same rate as a healthy person would. Symptoms of cervical cancer. Bleeding after sex is a big one. Having excessive vaginal discharge, particularly if it's very foul smelling, and having bleeding between your periods. A lot of women will have no symptoms. So when people have HPV, the normal cervical cancer cells see the HPV and then they undergo changes. They undergo precancerous changes, and then eventually that change will become cancer of the cervix. The time it takes to go from normal to cancer is about 10 to 15 years. So it's a long time. However, there are specific types of HPV that are more aggressive than other types. So those can progress from normal to cancer in a much shorter amount of time. Pap smears are how we screen for cervical cancer. This is the only screening test we have for a gynecologic cancer. So when you go to your doctor, your gynecologist, and they place the speculum in the vagina, they take the sample that's looking for cervical cancer. It does not look for uterus cancer, ovary, nothing else, just cervical cancer. The pap smear looks at the cells to see if they look normal or if they look concerning for cancer or precancer. A lot of places are now doing HPV testing with the pap smear to see if you have HPV, and if you do, if you have an aggressive strain of HPV. There is a cervical cancer vaccine. It's called Gardasil, and in the US, it is approved for both males and females starting at age 9 up until age 45. HPV causes not only cervical cancer, but also other cancers that can affect both men and women. The other cancers it can cause that can affect men are head and neck cancer. These are very difficult cancers to treat. And that's why we give this vaccine to both males and females. The vaccine itself cannot cause HPV infection, and it certainly cannot cause cancer. It's not capable of causing either of those things. People they produce a better antibody response to the vaccine than they do to natural infection of HPV that we have found. The ideal situation is for people to receive this vaccine before there is any sexual contact, before sexual debut, which is why in the US this is recommended as a routine childhood vaccine. Because if you've already been exposed to HPV, that vaccine is not going to work against that type of HPV. So this just shows that we only have this vaccine here in the US. It's Gardasil. It's called Gardasil vaccine. In the US, this is if you get the vaccine before age 15, it's 2 doses. If you get it after that, it is 3 doses. It's typically well tolerated. If you have an allergy to yeast, you should not take this vaccine. Or if you have a very bad reaction to the first dose, you would obviously would not be a candidate for the next doses. Yes, we talked about this, and then I don't really recommend vaccinating pregnant women just because we don't have data on that, but it's not been shown to be harmful, but we usually wait until after the woman delivers. So this vaccine really does work in the prevention of cervical cancer. So I have some numbers here, but what I will say is in countries where this vaccine has had nearly 100% uptake, they have eliminated cervical cancer completely. Countries, specifically the one I'm thinking of is New Zealand. They've had excellent kind of vaccination campaigns and really just, they don't see cervical cancer there anymore. Um, the US data is not great for vaccinating our population against cervical cancer. I remember when this vaccine came out, there was a lot of concern, especially in conservative communities in the US, that children receiving this vaccine would make them more promiscuous. Really, a variety of studies have shown that's not true. So the summary here is that HPV vaccination should be given before the onset of sexual activity. Um, Make sure you get your pap smears at your gynecologist or your primary care office and quit smoking because smoking will make it harder for you to clear HPV. So the summary here of the talk, 40% of endometrial cancers, uterine cancers, are preventable by maintaining a healthy weight. And that postmenopausal bleeding, always you have to see a doctor if that happens to you. For ovarian and fallopian tube cancers, 5 to 10% of these are thought to be genetically related and so can be prevented by knowing your family history. And what would happen is if someone, let's say someone is 35 years old, they have had all their babies, and they find out they are a carrier for an ovarian cancer gene, what we would do is talk to them, and we would actually remove the ovaries and fallopian tubes through a small surgery in the operating room. And then further hormones, we can give them hormone replacement therapy, but then that really eliminates their risk of developing ovarian or fallopian tube cancer. And then for cervical cancer, this over 95%, and I would argue this number is even higher, over 95% of cervical cancers are preventable through HPV vaccination. And that's all I have, so I'm going to stop sharing, and I see that there's a few questions. Okay. So let's see. So I'll just start at the top here. What leads to colon tumor and polyps? So I'm not a doctor that treats colon cancer, um, but yes, and this other question, if a colon tumor is still benign stage, is it advisable to go for surgery? I would recommend that you speak to a colorectal surgeon about that. But I do know that even when colon tumors are precancerous, they do often advise to go for surgery so that it doesn't become cancer. How young can a premenopausal woman get ovarian cancer? Young, young. I think maybe the youngest I've seen was 21, 22, especially if this is a family with, genetic carriers for ovarian cancer. There's, really no limit. Do women who have had a hysterectomy still need a gynecologist? Yes. Yes, you do. Because you know what? You still have a vagina, you still have a vulva. Um, Even if you've had all of the internal organs removed, you still need to see someone to make sure those other organs don't have cancer or any concerning changes. Can you expand on vulvar precancer? Yes. So I didn't talk about vulvar cancer because it's a rare cancer. We do see it. Vulvar cancer, essentially, it's the same process as cervical cancer. It's also caused by HPV. It's managed very similarly to how we manage cervical cancer. If someone has a vulvar precancer, we typically depend. It's an extensive conversation, but it depends on what level of precancer it is. If it's just VIN1, which is the first stage, typically this can be watched. If it's VIN2 or 3, which is vulvar precancer 2 or 3, we would usually remove this with a small procedure in the office or in the operating room, and then observe. Why are pap smears not recommended for women after 65 years? So that's the recommendation if they've always been normal. So if a woman has made it to 65 years, has always had normal or low grade pap smears, and does not have a high risk type of HPV, her chance of getting cervical cancer is very low. So it's been deemed to be not cost effective by the powers that be to not do the pap smears anymore after that age. Okay, what if a pelvic ultrasound shows a 4.4 centimeter right adnexal cyst? Um, um, I would need to see the ultrasound. It's a little bit of a vague question. So, ovarian cancer can be any size. It's not always just really big masses. I did a surgery yesterday. The patient had a mass 17 centimeters. It was huge. It was benign. And I've had patients with very small masses that are cancerous. So really what we look at is different features on the ultrasound. Some features are more concerning for cancer, some are less concerning for cancer. Just having a cyst, that is benign is not a risk for ovarian cancer. I see that was the next question. But so having a benign cyst is not a risk for ovarian cancer. Does anyone have any other questions?
The floor is open.
Okay. Thank you, Doctor. How young is advisable for I would say, young girl to do the HPV testing?
The testing you don't have to do until age 21. And if you are not, if the girl has never been sexually active, then it's not needed. But age 21, and the reason is because, as we know, children are strong, and they usually can clear infection independently by themselves. So we don't want to test unnecessarily and cause intervention too early when they really would have just cleared it on their own.
Can I ask a question?
Of course.
Yeah, I know the kids when they were young, when our children are young, like age of 40, 50, when they're in high school, they get the HPV vaccine. You said they
Mhm.
are more protected, right?
Yes, children develop a better response to the vaccine than adults do.
Because I know they gave them 1 and 2 that time when they were in
Hmm.
high school. They gave the boys and
Yes.
the girls.
Yes.
All right, thank you.
Thank you.
You're welcome.
Any more questions?
Aren't you working today?
I got called off last night because my event manager was supposed to go to the new location,
Mute yourself. We can hear everything.
but then the district manager called my event manager to
Mute.
say, I go to the new store, stay at your store, which then called me.
Is there any more questions? Okay, can you give us like any resources that we can go to look for education on ovarian cancer, cysts, and everything?
Absolutely. So two resources that you can go to online. One of them is called the Foundation for Women's Cancer, FWC. This is a nonprofit that does a lot of work in spreading education and campaigning about GYN cancers. The other one is the Society of GYN Oncology, SGO. And that's our professional society for GYN oncologists globally. And this has a lot of excellent patient information as well regarding GYN cancers.
And you said if somebody's above 65, they don't need to do spice or something. They don't need to do the what they call it, the sperm. I forgot.
Pap smear, yeah.
Pap
But
smear,
it's
pap smear.
fasting. Yes, sorry.
Yes. So if a woman has had all normal pap smears her whole life and she made it to 65, no abnormalities, she can stop having pap smears because it's very unlikely that she will develop cervical cancer. However, you still need to see your gynecologist. You just don't need the sample, but you still need an exam.
Thank you.
You're welcome.
I have a question. So you said the HPV vaccine can be given to women up to the age of 45. Is that correct? So as a healthcare
That's right.
provider, are you supposed to be, recommending that for patients, or it's just a discussion between them and their gynecologist? I know,
What's the program?
part of preventative healthcare for teenagers and young, adults, they do promote HPV vaccinations a lot. But for middle-aged women, I don't see them, talking or encouraging that.
Yeah, well, that is wrong. They should be talking and encouraging that.
Yeah, because I'm just
Yeah, they should be. They should be talking and encouraging that. Honestly, when I have patients come to me, even with, well, I only see patients with cancer. So if I have patients come to me even with cervical cancer and they didn't receive the vaccine, I actually give them the vaccine because they have cervical cancer from one type of HPV. They don't have all, hundreds of strains of HPV. So at least they'll be protected from the other ones. But absolutely, up until age 45, this should be discussed with people.
okay. Thanks.
Yes, I think what she said is true. When the kids were young, they really promote it on the kids. I think towards the end, 2016, 2014, I think it just came out that time. They really promote on the kids that the kids should get it. They don't really discuss it about the older people that, oh, you older people should go and get HPV. But most of the time they allow the kids because in the school they make sure they gave it to them. So, like she said, I don't think there's more promotion on the elderly people or the older people. That's what I feel because I think they really promote it more on the younger ones than the older ones.
I totally agree. I mean, this vaccine was created to be a vaccine for for children. The approval until age 45 is relatively recent, within the past few years, even maybe the past 5 years. So a lot of people, a lot of doctors, if they're not gynecologists, they don't, are not following up. They don't know. They don't know that this goes until age 45, but in the US, it is approved until age 45. Your insurance will cover it until age 45 for men and women.
Thank you.
Oh, there's a question there that say my daughter is always having pain during the period. Is that normal, and what medication can they use?
It can be normal. It's not always normal. I always recommend, so when this is happening, to at least start with the child's pediatrician. If it's a child, and if it's a woman, an adult, she should talk to her gynecologist so they can get the full picture. It's very hard to give medical advice when I don't have the patient in front of me and I can't do an exam. So I'm sorry to be vague in the response.
Yeah. Thank you. And I think we women too, we can be an advocate. So let us tell one person, the person tell another, so we all can be advocates for each other. So it's the community education. We all educate each other. So if there's no more questions, thank you very much.
Thank you.
Oh,
Thank you, everybody.
okay.
Have a great day.
Thank you.
On behalf of the executive and the entire membership of Eko Club, we sincerely appreciate your outstanding presentation on gynecological cancer awareness. Your expertise and in-depth knowledge on this topic were truly commendable and greatly valued. Thank you again, Dr. Saleh.
Thank you. Have a
Thank
great
you.
day,
Thank you. We
everybody.
appreciate
Thank
you.
you.
Everybody.
Thank you.
Yes, thank
Bye.
you.
Thank you.
Yes, doctor. Thank you so much.
We appreciate you.
Thank you.
Thank you again. Bye.
Bye. Bye. Thank you.
Bye.
Bye. Bye.
Bye.
Bye, man.
Thank you. Bye,
Thank you.
Mao. Thank you, go.
Everybody.
Thanks for inviting us.
Blessings to all.
Blessings, oh, blessings,
Happy
oh.
Women's Day.
Happy
Same to you, ma.
International Wednesdays.
So we should
Thank
all
you, ma.
Wednesday.
take care of
Thank
our,
you. Thank you.
Thank
Sure.
you.
Okay, bye.
to all continue to take care of ourselves, please.
Thank you.
Yes, thank you all.
Thank you.
So we are coming to with the main stuff.
Honorable Cass.
Mine.
Yeah. All right, thank you, everybody. So be on the lookout for more education.
Yes, ma'am.
Bye. Have a blessed day.